I think that these concerns are way more common than we even realize. But we have a lot of tools in our toolbox. And even though there's not one single treatment that's going to help, it might take 10 different ones to get someone a little bit better. But let's try those 10 different ones.
Hi, I'm Dr. Joseph with During. It's my pleasure to be joined by Amy Perlman today. She is a urologist, so that's a physician who's done specialty training in urology, and she's here today to talk to us about post SSRI sexual dysfunction. Um, she's been talking about this topic for a while, has done lectures about it, and I thought it would be really nice to get the perspective of a non-psychiatrist, a urologist, on what's unique about PSSD, how she thinks about PSSD, how she differentiates it from other conditions, and I think that would be really useful. So, Amy, welcome, and why don't we just start by you telling us the story of how PSSD even turned up on your radar to begin with?
Thank you for having me. And
Yeah.
I'm excited to talk about this topic, even though it's a really terrible condition. But I think at the very basic level or foundation is we have to talk about it. We have to talk about it a lot, right? Because we got to get people no time, at any point during probably your training. And I know certainly no time in my training, despite like 15 years of training, did we ever talk about conditions like this. We use a lot of medications. You were in pharma, right? So we use medications
Hmm.
all the time. But the thought is that if someone has side effects, once the person stops the medication, the side effects must go away. They may not go
Hmm.
away immediately, but eventually, once the medication is out of the body, the side effects should go away. But what if they don't? And so the condition with PSSD and post-finasteride syndrome really bring up this point of persistent side effects or new side effects even after stopping a medication. So I was at a big academic institution in the Midwest for about 5 years, and I directed the men's health program there. And during that time, I'm a woman. So I specialize in men's health. A lot of
Hmm.
urologists, see people of all genders, but a lot of my patients were sex assigned at birth, male and identified as male. So that was the majority of my patient population. So when I ask my patients questions, I'm asking them questions for the sake of really understanding what's going on and not making any assumptions. And I saw a few young guys in my clinic who had really good questions and knew enough about and had looked things up on the internet to find things like PSSD and PFS where they could bring it to my attention. I had never heard of it before. And so I had a couple of guys come in who were young. They were, maybe late teens, early 20s. And they would say things like, I took Prozac for 5 days and this is what happened. I took Propecia because I didn't want to lose my hair, wanted to prevent that, for a couple doses. And this is what I noticed what happened. And even though I hadn't heard of these conditions before, I went on Dr. Google, right? And I know we oftentimes poo-poo people and we say, oh, okay, you're going to listen to Dr. Google and you're not going to listen to your doctor. The reality is we all go on search engines and we all look up these conditions, and we all should look up these conditions if we haven't heard of them before. It gives us a place to start. So I started looking into it and I started reading up on some of these conditions. And interestingly enough, one of the researchers who had written on informed consent related to SSRIs was actually at my institution. And a few years prior, she had tried to educate people and tried to change, some of the lingo and how we treated young people with SSRIs. And she hit a lot of roadblocks. But that's where I began. I started having patients reach out. The researcher, was at the same institution, and I just started asking a lot of questions.
Hmm. And question like to other colleagues or other urologists, other people who are experts in antidepressants, is that kind of where you went?
Yeah, the researcher, she was a psychologist and she
Hmm.
actually worked with college students. So she worked in the student health department. So I knew, based on her experience, she was seeing a lot of these young people And kind of from her perspective as a psychologist, she was deciding like, when does this person need to see someone else, let's say for a prescription for an SSRI, but she would also talk with people about their experiences and really provide some informed consent.
So, I mean, what was your experience like? Okay, so you're hearing this from your patients. You go online. I imagine you find the communities because they're pretty vocal once you start looking for them. What was the reception that you received from colleagues when you said when you started asking questions about this, or asking whether they'd heard of it or had any experience? What was that like?
So it's interesting because when we think about what a urologist does, a lot
Hmm.
of people think that a urologist specializes in men. But the minority of urologists actually treat male quality of life concerns. So let's talk about what the majority of my colleagues and urologists treat. They treat prostate conditions, whether it's for non cancerous but also cancerous reasons. They treat
Hmm.
bladder conditions, kidneys, kidney stones. And so, actually, the minority of urologists actually specialize in sexual health, whether it's men's health or women's health. And so, really, at my institution, I had the opportunity to really lead the charge when it came to seeing men with sexual health concerns. So, within my department, I didn't really have anyone to go to per se. I was the
Hmm.
specialist, okay?
Okay.
Now, interestingly enough, when it comes to PSSD, a lot of urologists we're not really prescribing those medications. But what we are prescribing is finasteride, and we're prescribing finasteride for our male patients who have enlarged prostate.
Hmm.
So that's also where I had somewhat heard of conditions like this with post-finasteride syndrome related to a medication that a lot of urologists prescribe. So I did discuss this, and sometimes I would bring it up in conferences because we were, teaching trainees. And I would bring up, some of the sexual side effect concerns that I had with finasteride and would bring up terms like post-finasteride syndrome. But a lot of my colleagues didn't really believe that it could happen. I remember one person in particular saying, well, maybe the person who comes in with concerns for losing his hair, maybe he's just like a different type of person, that would also experience sexual side effects. Maybe it's just a different person. And because of my colleagues were, for decades, they had been prescribing medications like finasteride, and maybe no one told them that they had sexual health concerns. I don't think they quite believed that it could happen. But the big difference here between a lot of the patients as we as urologists prescribe finasteride for, they are older patients. They are guys in their 60s, 70s, and 80s with enlarged prostate. So if those guys who are older come in and they say, I have decreased libido, I have erectile dysfunction, there
Hmm.
are so many things we can blame it on. We can blame it on their heart disease, low testosterone, their diabetes. So it's a very different patient population than the guy in his 20s who's taking, a medication like finasteride for male pattern hair loss or an SSRI.
Yeah, I mean, that's something that, we see a lot, that I've seen a lot, is, when the side effect comes up, they look for something within the patient population. So for instance, this young guy, he's taking finasteride, maybe, he's anxious because he has thinning hair and that's contributing to some performance anxiety. You're probably reading too much into this. That's what you'd expect because, I mean, the same thing happened when people became suicidal on isotretinoin a long time ago when they were looking at Accutane. They'd say, well, these people have, they have acne that could be associated with poor self-esteem, body image issues, and maybe there's just a higher likelihood of that happening there, and so on and so forth. But it's different. And the the other thing that you mentioned, which is interesting, is that it's one, people aren't going to mention it to their doctors because no one, I guess people aren't very comfortable talking about sexual health. And then two, when someone's older, there's a lot of alternative explanations for what's going on, and I think maybe this is a nice segue to kind of talk about the differential diagnosis, when a young person comes in who's saying, you know, I'm having, severe erectile dysfunction, things, I've got muted orgasms, things have really changed for me, and maybe they've just stopped an SSRI or just come off finasteride or Accutane or something like that. What's the differential? I mean, what are you and your colleagues who specialize in men's sexual health thinking about when someone's coming forward with these problems?
Yeah, and the differential is different depending if we're talking about an older person versus a younger person. Because in the older person, I'm really focused on what medical conditions does this person have. Heart disease being the number one risk for erectile dysfunction, diabetes being number two, and we know that those rates are only going up. I'm also thinking about and asking about surgeries because a lot of these older guys will have had a prostate procedure, let's say for prostate cancer, which is also, highly likely to cause some degree of erectile dysfunction. But in the younger patient population, I'm really asking more like social history, medication history, more of like, so 5 years ago, was everything okay? And then what happened? Did something happen between then and now? I like to ask questions like, what do you think is going on?
Hmm.
What comes to mind? What do you think may have caused this issue to happen? So much of my goal with those conversations is to help that person come to their own conclusion. Because I know this is not the first time they're thinking about it, and maybe they have some sort of idea about what happened. I'm
And
not
can
at
I?
home with the patient, right? So
Yeah.
I have to ask these questions to really understand what that person's life looks like outside of the office, what that life looks like, the many, many hours out of the day. And I'm just seeing them for, let's say, 30 minutes to an hour. There's a lot that goes on.
And if I were to infer from that, that how you focus your questioning is you're focusing on, I guess, contextual stresses in their life, what their life looks like. Is that because, in a young person, when they're complaining about sexual dysfunction, the number one thing to consider is, I guess, mental health, being involved in that. Is that a correct assumption?
Yeah, and we try to
Okay.
separate it out into, is it
Hmm.
a mental health or a psychological thing or performance anxiety thing versus is it more of a physical issue? Because in young people, they're less likely to have heart disease and diabetes,
Yeah.
right?
Hmm.
But I don't like to really separate out the two because the reality is whatever happens in our brain, which our brain is really like the sexiest organ, but all the signaling begins in the brain. So emotions that we feel, happiness, frustration, excitement, stress, it's not just emotions, right? They're chemical reactions, signaling molecules that are released. And those signaling molecules have direct effects on the erectile tissue, but on the genitals, period, regardless of what genitals that person has. So if someone feels, let's say, anxious about a physics exam they have coming up, and let's say they're with a partner, a week before their exam, they might be excited to be with their partner and maybe they're not thinking about their physics exam, but that stress going on in the back of their mind is sending signals to their penis to say, we're not going to work. So what do those signals look like? Well, in order for a guy to get a good erection, he needs the blood vessels to open up, to vasodilate. But stress molecules, okay, what do? They constrict the blood vessels. So no
Hmm.
matter how bad he wants it, stress, anxiety, that adrenaline response will close off those blood vessels. So it's really, for anyone who has, concerns about pleasure or dysfunction, whatever, there's always going to be a component up here, a brain signaling component. So I like to say it's not in the mind, but it is in the brain.
Okay. And I guess another thing, if I think about things that affect the brain, um, what are you asking about in terms of psychoactive substances, whether they're legal or illegal, and how do you think about the effect that they could play, in a young person that comes in who's complaining of erectile dysfunction and such?
Yeah, that's a really good question because more and more research is coming out to look at those factors, but so many of the studies we don't really know, right?
Hmm.
And so we know, for example, when it comes to alcohol, a little bit of alcohol can be helpful, but a lot of alcohol can be very unhelpful, right? There's a term that we call what can happen if someone drinks too much alcohol.
Hmm.
And I always like to go back to the how the penis works, right? So we were talking about blood vessels opening and closing. So if we think about the effect of nicotine, and even if someone is, let's say, not using tobacco-containing products, but they're using e-cigarettes,
Hmm.
so nicotine is oftentimes in those products. So what we know about, nicotine is that it closes off the blood vessels. So it may not cause erectile dysfunction in everyone, but when we just go back to what opens and closes, I talk to my patients about nicotine containing substances and that it can close off the blood vessels. When it comes to marijuana products, the research is a little bit all over the place. Okay. I was able to do some education for over 200 men in fraternities. And so we just spoke about common men's health concerns. So there were some questions that I got from the audience that
Hmm.
said, well, that guy in the red shirt, he has a question and he wants to know what is the impact of, let's say
Yeah.
cocaine on sexual function? Or, hey, I have a question. What do gummies do when it comes to sexual function? And in terms of, gummies and marijuana, those types of products, like I mentioned, we don't really know. So I simply ask people, do an experiment on your own body, right? If you use anything, and whether it's just eating certain foods, not even illicit substances, right? If they drink water versus soda, whatever it is, then pay attention to your body. Do you feel like, what is the impact on how you feel overall, on
Hmm.
your body image, on your libido, interest in sexual activity, and on your erections? Because the reality is we can be our own experiments with so many of these, medications too, or, drugs. When I see online and different things that are posted, there are some people that say it works awesome. It really helps. It helps me feel more comfortable. I'm relaxed, so I enjoy it more. So the reality is there's not going to be a single study that really tells us what to tell people. They're going to have different impacts on patients. Now, that's not me saying, yes, we should use illicit
Yeah.
substances, we should use drugs and experiment on ourselves. That's not what I'm saying at all. The reality is we just don't know what the impact is on sexual function in particular.
I think that's really good. What you said is that sometimes it can go both ways. It could be positive for someone or negative for someone else, and then sometimes it can turn on people. It may start off as a positive experience, but over time, the drug just either stops working or makes it worse. Another thing that comes to my mind is I know a lot of the people that might be watching this, we're very familiar with SSRIs, essentially most psych drugs, Accutane and finasteride causing sexual problems. Are there other drugs out there that may cause sexual problems, even if they're not enduring, that you're like, drugs that a doctor would prescribe that are on your radar when you're doing these evaluations to kind of rule out other things?
Yeah, there are a lot of other medication
Yeah.
classes. The big ones I'm looking at when I look at someone's medication list are going to be the mental health medications. And
Hmm.
so, what I tell patients whenever I see those medications or others is I say, let me circle the medications that may be contributing to your sexual dysfunction. But I make it clear. I tell them, I don't want you to just stop this medication, but I do want you to go back to your prescribing provider and ask that person, might there be other medications that can still treat what I need this medication to treat, but ones with fewer sexual side effects? So the other medications that have a higher likelihood of causing sexual dysfunction are going to be medications for blood pressure, things like
Mm.
hydrochlorothiazide, which is a diuretic, beta blockers. So again, these are not medications we just want to stop, and it's really important that we control blood pressure because going back, heart disease is the number one cause of ED. So we have to treat the blood pressure. But there are other medications that don't have as high of a risk as causing sexual dysfunction.
Okay.
Mm-hmm.
And in terms of well, I guess maybe a safe way to say, if I were to kind of cast a big lumping category, is that any kind of drug that maybe acts on the central nervous system, or any kind of drug that modulates blood pressure in some way, just from a mechanistic perspective, could be playing a role in sexual functioning and may be worth looking at. Um,
Absolutely. And the
Yeah.
reality is there are plenty of medications that, based on the research, have a higher likelihood of causing sexual dysfunction, but don't cause some people sexual dysfunction. There are other medications that my patients have brought up, and they said, I started on this medication and I started noticing issues. Or, you know what, I stopped this medication and my erections got better. So even though they're not in the literature as having a higher rate of sexual dysfunction, just by starting and stopping and paying attention to one's body, we have to believe them that they can make an
Yeah.
impact.
That's so interesting because I know in psychiatry, the thing that, constantly trips people up is when people are on immunomodulatory drugs or dermatology drugs. And we often think, this doesn't have a role with, your psychiatric symptoms, but in many cases they do. And then the longer the drugs stay on the market, you start seeing that the labels discussing these kind of psychiatric effects, and we have no idea how they're really caused. But yeah, also any drug could potentially do it as well. And the only way you really know for you is by kind of like you said, this experiment, maybe stopping it and seeing how you respond. Um,
And journaling, right? I mean, people
yeah.
try a lot of different medications. Sometimes it's hard to exactly tease it out. So, people keeping their own record of what are my current symptoms? And when I started this medication, what did I experience? Keeping that log can be really helpful. And I think we also, as healthcare providers, have to get comfortable with not being able to explain why something is happening. If someone comes in with A and B, just because we don't know how to explain the link doesn't mean that association is not occurring.
Yeah. Um, Another thing I want to ask you about is as so as a clinician who interviews a lot of people with men's sexual function problems, and also someone with an academic background. How do you, just from like a clinical perspective, tease out um, maybe post finasteride, post Accutane, or PSSD from I guess the other types of sexual dysfunction, probably namely the anxiety related one, and then also maybe the ones that have to do with cardiovascular disease. What are you looking for in how your patients kind of describe these different constellations of symptoms or patterns that help you say, I really think this is, you might have risk factors for all of them, but I really think this is kind of what's going on. I'd love to hear how you think clinically, about these things.
Yeah. And,
Yeah.
I'll ask questions like, when do you have the issue? Is it all the time that you have issues reaching climax, ejaculating, getting an erection? Or is it only in certain circumstances? So the guys where it's going to be more of, let's say, a performance anxiety type thing are going to be those who don't have any issues when they're by themselves and masturbating, but it's when they're with a partner that they have issues. Or, I'll ask them, do you wake up at all with, during the nighttime or in the morning with an erection? Because that would tell me if they have nighttime and morning
Hmm.
erections, oh, their anatomy is fine. They're able to get good erections. It's just when, let's say, they're with a partner, right, where then they have issues. So that's telling me it's more of like a performance anxiety. At the end of the day, though, the treatment is largely the same. So what I mean by that is there are plenty of people that didn't get, let's say 20-year-old guys who were not able to perform in a certain circumstance. So the next time they're with a partner, they're thinking, am I going to be able to perform? Should I even initiate? And then they kind of go down this rabbit hole. And even though I know in that circumstance it's likely related to performance anxiety, I also know I just need to help this guy with his confidence. He needs to get some really good erections, build that confidence back up to get out of his head, to get out of that rabbit hole. And
Hmm.
so I will, routinely prescribe medications like Cialis in those guys to help them get erections, even though it may not be, what we would consider to be a physical problem. So largely the treatments are the same. Even the guys who have heart disease and diabetes, where I know it's a problem with the blood vessels and the nerves, I oftentimes suggest those guys also see a sex therapist. So
Hmm.
everyone can benefit from a sex therapist. And a lot of people can benefit from medications like Viagra, like Cialis, using vacuum pumps or constriction devices. So the tools that we use for one person are oftentimes the same tools that we would use for anyone coming in with sexual dysfunction. When I think about guys who might have issues reaching climax, let's say due to decrease in sensation, I routinely recommend vibrator products or sensate therapy, or just understanding other parts of the body that can feel good that might be separate from the penis. But you know what? Another guy who, let's say, doesn't have an issue, he doesn't need to have an issue to benefit from a vibrator or, from sensate therapy. So even those techniques that we would largely reserve for, let's say, a sex therapist or a psychologist can benefit every single person who's a sexual being.
I'm going to pick up that thread in a second because I think that's going to be a really interesting one to talk about. But I want to just ask again, maybe a little bit more about PSSD, PFS, and post-Accutane, and the sexual dysfunction from cardiovascular disease. How do you tease those two apart? Like those two conditions. Like, what do you notice about the difference between them clinically? Maybe aside from I guess the historical, clues.
What I find is that even though we call, post-SSRI sexual dysfunction, we have the sexual dysfunction in there. I find that it's way more encompassing than just sexual dysfunction. I mean, would you agree? We
Hmm.
focus so much on the genital area, but a lot of these patients also report brain fog. I've had someone describe, I used to feel crushes on people. I don't feel that way towards anyone anymore. A lot of people also describe genital numbness. And so that's very different from the guy that I will see who's 6 years old, who has fine penile sensation. He can orgasm. He just needs, help getting erections, to the patients who come in who have really way more broad symptoms, maybe GI symptoms. That's very different. What's
Yeah,
your
I think.
experience with that?
Yeah, no. So I know the people that have PSSD because I've spoken to quite a few of them now, and they actually have some quite unique symptoms. Yeah, so the genital anesthesia is, um, I guess, the one that a lot of people talk about, but the cognitive effects that can happen are really unique. It's people say it's like a depression, but what I hear, it's an intense level of dissociation where they feel almost like separated from their body. They often describe like feeling, it's like they're watching their life on TV, or they're like a robot. And part of, I think, the sensation that causes that is that they have this intense blunting of emotions. And when you're used to a state where you would be able to relate with people, and you used to feel like warm and fuzzy when you would hug someone you love, or you'd get goosebumps on the back of your neck when you listen to music, when all of that goes away and all of that sensory pleasurable feedback that you used to receive is turned down, you feel like life isn't real anymore. So they describe a lot of that sensation of intense disconnection from the world. Some people have pretty significant cognitive problems as well. And this is something that you should ask about, next time you're seeing these patients, is ask them how they respond to drugs and alcohol. Because the people who have PSSD and PFS, some of them feel nothing. And this is what I also think is probably one of the unique symptoms about this. They do not even feel euphoric when they consume large amounts of alcohol. I spoke to someone recently who did an ibogaine trip, who felt essentially nothing, which is meant to be a really intense 14-hour kind of long thing. And so those would be the things that I would look for, general anesthesia, intense kind of blunting and disconnection, and also abnormal responses to drugs. I think that's something that's really strange, and what I see a lot. Yeah.
And so much of, in people in general, but really young people, is, being able to pleasure oneself or be with a partner and experience pleasure and orgasm is a coping mechanism for a lot of people. It's a way to like de-stress and to feel good and to get that dopamine rush. And so when these
Hmm.
people aren't able to reach kind of like that climax, they don't, they're missing something, and they've a lot of them have experienced it before. And so they're trying to figure out, like, how do I get back there? And they're unable to do that. And it's very devastating for people.
Hmm.
But it's very
Um,
different from just, the penis not being able to become erect. The symptoms are quite different.
are there any, sorry, just gonna ask again, are there any endocrine disorders? For the audience, this is problems with like the hormones, the hormonal system that are on your radar when you're about evaluating sexual dysfunction that you think about.
Absolutely, and I'm
Yeah.
definitely checking, testosterone in these people. At the end of the day, a lot of these people who have PSSD, PFS, what I published a study in 2021 to really understand, like, what are people trying, and the reality is people with these conditions are trying a lot of different things to see what might work. It's really like the kitchen sink of different tools. And so, as a urologist, as a healthcare provider, I'm thinking from my perspective, I want to treat and optimize everything that I can to maybe make some dent in this person's symptoms. So I'm thinking about, related to the erectile dysfunction, what tools in my toolbox can I use to help with the function? I'm thinking, how can I help with the sensation? What different products can help with that, or medications? And then I'm thinking about the hormones. I don't want to miss a hormone issue because I can treat hormone issues. And
Hmm.
even though, treating, let's say, someone who has low testosterone with testosterone therapy, is that going to cure or reverse all of the symptoms commonly associated with PSSD? The likelihood is no, but I'm just trying to make a dent, some sort of change that can help that person. I typically start by checking a testosterone level in the morning. And then, depending on what that level is, if it's on the low side or low side of normal, then I'm checking some of the signaling hormones, like the pituitary hormones. I'm checking LH. If someone is interested in fertility, I'm checking FSH. I'm checking prolactin. I'm checking estradiol. Those are some of the other blood tests that I'll check.
Do you check the female sexual hormones in men as well, or do men usually just get the total T and the maybe or yeah, yeah, I'm just
Yeah,
curious.
so
Yeah,
I check them all, and
yeah.
and estrogen is really important in men. And we
Hmm.
think about, some men say, well, I don't want estrogen. I want you to lower my estrogen. But the reality is, we don't want to lower the estrogen to zero, because estrogen is really important for bone health, and it can really play a role in someone's mood. I've seen guys who, let's say, when I'm, putting them on testosterone, sometimes their estrogen level goes up too high, and sometimes I drop it down so it's too low, and they feel a difference. So there's an optimal level of estrogen where guys feel good. But it's the same thing in women. Like, we also want to check, in some women, testosterone. And in some women, they might be good candidates for actually giving them testosterone therapy. Because in someone like me, yeah, estrogen is going to be my main feminizing hormone, but I also need testosterone for a lot of aspects of my daily life. And not even just related to sexual function. So often, we focus so much on the impact of testosterone and estrogen on genital function, but these hormones play a role in every aspect of our body: how we think, our cardiovascular health, and our genital health, as well as so many other daily functions.
Could you share? Some people in the audience, and also I want to know as well. They may not be able to see someone like you who's kind of has this experience, but maybe they have a good family medicine doctor who's willing to kind of look at these things. What would a lab order look like if they were saying, "Hey, I want to know a little bit more about my hormones." What would that order form look like if they were to coach their family doctor to put something together like that?
Yeah, absolutely. And I think it's always good to start with just basic lab work. So,
Hmm.
if someone doesn't have a recent, electrolyte panel, that's good. Complete blood count, a CBC, is also helpful. In terms of a hormone panel for a man, we're typically going to start off with that testosterone level. If that initial testosterone
Is that
level is
total or free?
I typically start with a total testosterone.
Okay. Yeah.
But
Yeah.
yes, there is a little bit of controversy there because the total testosterone doesn't necessarily give us the full picture. But I oftentimes just start there to see where we're at. If the total testosterone is well within the normal range, then depending on the person's symptoms, I may not check additional hormones. Okay. I tend, though, to check some of those additional labs, okay? Even if the testosterone is normal, because I don't want to miss something that I could potentially intervene on, right? And I think prolactin's important and estradiol, and you're not going to find this necessarily in the low testosterone guidelines for someone who has a completely normal testosterone, but it just gives me more information. And information in this patient population in particular can be helpful and at least can provide us some reassurance that we're not missing something.
Great. And okay, so I'm going to pick up the thread that we left before, where you talked about all of the different ways that you might help someone who's having something like PSSD. Obviously, there's no cure for this apart from time if some people are lucky, but there are different symptomatic treatments. So I'd love to hear all the different ways that you would look at this problem and might suggest different, treatments. I know you mentioned vibrators and things like that, sex therapists. So yeah, I'd love to get your full download on all of the things that someone might do if they're in this position.
Absolutely. And I do want to preface it by saying that I have colleagues that are really smart and talented that are working on it. We're trying to figure it out. I got a lot of people reach out to me from around the world over the last couple years with concerns for PSSD and PFS because they saw some of the research that I did. Now, my research that was published in 2021 was just trying to better understand the condition. So we actually had over 200 people respond. We posted this survey on online support groups, and we were trying to figure out what people have tried and what their symptoms were. But it didn't tell us, what people could necessarily do about it, okay? But I do want to emphasize that I do have colleagues in the sexual medicine space who are trying to figure this out, and I do want to give people, some hope there. I also have colleagues that have a lot of experience treating people with this condition. And even though there's not one single treatment or two or three that routinely show benefit, I do have colleagues, like for example, Dr. Rachel Rubin. She's a female sexual medicine specialist in the Washington, D.C. area. She has particular expertise in this condition. San Diego Sexual Medicine is a group in, obviously, San Diego, and they have particular expertise. And so I think the key when people are trying to find providers who might be able to help is to understand, you might have to travel to a different area of the country to access this type of help. You also want to make sure you see a provider who can they need to be able to sit down with you for an hour, 2 hours, 3 hours to really understand what's going on and be able to provide access to regular follow-up, because these are the types of providers that are going to work with you to try different things to see what might work for you. And there are providers out there, who kind of try a lot of different things and they've been successful. In terms of the things that I will try, I use all the same tools that I would use for anyone coming in with sexual dysfunction, whether or not they have a history of using an SSRI or finasteride. Because sometimes, people will come in and maybe they don't know whether a medication caused it, but maybe it did, right? So it's all kind of the same thing too, where I'm just trying a lot of different products. When it comes to erectile dysfunction in particular, there are 4 FDA-approved medications to treat ED. You can get the generics for Viagra and Cialis for very low cost these days. There are medication assistance programs like GoodRx, where you could get a daily Cialis for $15 for 90 pills. So it makes it really affordable for a lot of people to try. The way those medications work is just by increasing the amount of time that nitric oxide stays around in penile tissue. So it just helps open up blood vessels, okay? A lot of people tolerate them just fine. Other options that I'll talk about are rehabilitation tools. People also describe changes in their penis. And if they're not getting regular erections, like any part of the body that no longer gets regular activity, if I were to lift my biceps consistently and then stop for a year, my bicep muscle is going to change. It's going to get smaller. So for those people where, let's say, the medication, the pill options aren't working, rehabbing the penis, exercising it is really critical to maintain the structure of the penis, to prevent the penis from getting smaller. Vacuum erection devices are easily available online. No prescription is needed. There are other tools like penile constriction bands that can help keep the blood in. There's a new product on the market, which I'm very excited about because I'm on the medical advisory board for it, and I know a lot about the product. It's called, if you go to myfirmtech.com, it's a wearable cock ring or a wearable penile constriction band. There are two iterations of this device. One, the person can wear, just to keep blood in the penis, but there's another iteration, a smart device that the person can wear, let's say, all night long, and the information will go directly to their smartphone, and it will tell that person in real time, how many erections did I get, how firm were they, and how long did they last. That can provide people with more objective information as they try different therapies to see what might actually be providing any type of benefit. It can also be beneficial to, share that information with a healthcare provider. Again, just getting us some more objective information. There's penile injection therapy, so a small needle where you can inject medication directly into the penis. And then for people with more severe erectile dysfunction, there's penile implant surgery. That would not be a common thing that we would be doing in someone who's young, but it is on the table. It is an option if all these other options are not quite doing the trick. When it comes to sensation, because that's sometimes one of the most devastating symptoms that people report, it's figuring out how do we increase sensation. Maybe we need more stimulation. We talk about vibrator products. We talk about anatomy of the genitals. That pudendal nerve that gives sensation to the penis is the same nerve that goes to the area behind the scrotum and the rectal area. So maybe by stimulating near the rectum or behind the scrotum, maybe that can cause, some type of pleasure and lead to a good sensation. But then even thinking above the genitals, we think about, let's say, like nipple play for women, but what about that for men? Like, what else on the body? Is it like a scalp massage that feels good? So it's getting a little bit more creative and not focusing so much on the genitals. And then it's finding a provider who acknowledges that this is a condition that can happen. I know that that's sometimes the most frustrating thing for people is they go to healthcare providers, they tell them I'm experiencing this, and they're told, well, that can't happen. And so it's just finding someone, I think at the very least, to sit down with to talk through what's going on. And that can be therapeutic.
And because the general anesthesia is such a common complaint that I hear about talking to these folks. Could you list maybe some products, maybe there's some brands or different, or the names of the products if someone wanted to go on Amazon or Google and they're looking for different, they just want to try anything, whether it's something that's a vibrator or it's something that, stimulates another area of the pudendal nerve, anything that's worked with your other patients, just so they would have a thread to pick up on and look for things.
Absolutely. We're going to take a little tour to the bookshelf. Okay, Yosef?
Okay, great.
I conveniently have a bookshelf right here. So we'll go down here. So some tools here, and these can be really good for both penis and vagina owners. But this is a penile constriction band that vibrates. So it can feel good for both the man wearing it as well as his partner.
And could you just maybe mention the brands as well, if there's a brand that you recommend or that you...
So We Vibe has really good products, and I don't get paid by any of these companies, but it's WE and then VIBE. They have really good products for people of all genders. Yep. And then let's see, there are bullet vibrators, there are smart vibrators, right, where you can control it from a remote. So that, those can be helpful for really anybody who wants to, let's say, have some control over their partner's pleasure, or, add some
Sure.
spontaneity and spice it up. So
Hmm.
let's see what else we got here. I have here's a penile constriction band. So this one doesn't vibrate, but this would help keep the blood in. This is the FirmTech device. So this is that wearable penile constriction band. One of these loops goes around the testicles, the other goes around the penis. There's a sensor in here, and that's what
Okay.
will pick up on the erectile function. Let's see what else we got here. There are other topical therapies like warming gels that can feel good for people. So, at the end of the day, when it comes to, any of these products, whatever feels good is good. If something hurts or is uncomfortable or someone's just not interested, then stop doing it, right? But there's a lot of ways that we can be creative in our sexual health, even for people who don't have problems, to really optimize the sensation and the experience.
It's thank you for showing us those things. And I want to ask also about the genital atrophy, because that's something that is really horrifying to people when they develop one of these conditions. And so, is your thinking that it's an underuse, that it comes, it's from underuse? Because I never really knew how to think about it. I was like, surely I was thinking like, maybe is there something like hormonal going on? Like, is there any like, how do you understand that when someone says, the shape of my penis changed, or it's looking like the stuff down there it's getting smaller? Like, like how do you, yeah, how do you think through that? Because I've struggled to really understand that.
Yeah, I've actually seen some changes on imaging. So
Yeah.
there was one guy in particular where on exam you could feel something hard in his on the bottom part of his erectile body. So we got an MRI, and you could see changes on the MRI that were very abnormal. And it wasn't penile cancer. It was like a fibrotic condition or a scarring condition. And so there, in some people, there can be actual, structural changes that happen. I emphasize in anyone who sees me, if they want to optimize the health of their tissue, they have to get good stretch and blood flow to that tissue on a regular basis. And you can do that a variety of different ways. If someone is taking, let's say, the daily medication, tadalafil or Cialis, to get good erections, then I think about that as exercising from the penis, or exercising the penis, or rehabbing it from the inside out. They're getting regular exercise. But other ways to pull blood into the penis are going to be using vacuum devices. Another device that I haven't mentioned yet is traction device. This is a Restorix device. You clamp the tip of the penis in that area right there. You clamp it down, and it can stretch straight out. Now, that device right there, you don't need a prescription for. You can get it online. And it was developed for guys who had scar tissue in the penis related to like Peyronie's disease that caused penile curvature. But more research over the last few years has looked at traction therapy for guys, let's say, after their prostates removed for prostate cancer, and noticed shrinkage. I use it in anyone who wants to help restore length that they've lost. Again, when we don't get regular erections, the penis, the tissue will atrophy and it gets shorter. I explain this to everyone. If you want to optimize the tissue, if you'd be upset in 5 years if your penis were smaller, we have to make sure we get it stretched on a regular basis. There are some guys that are very motivated that will say, I'm going to take Cialis, I'm going to do a vacuum pump, I'm going to use the Restorix every day, and they'll do it. And there are other guys that say, I'll do it once a week, right? But at least they know. The last thing I want is for someone to say 5 years from now, I wish someone had told me, because now we have the tools.
And so a lot of the people that I work with who have had this happen, they're really afraid of medications, and maybe I'm just guessing that the more of the Restorix and the vacuum pump kind of options would be more appealing to them, while they're recovering. What would you
I think that's
recommend
a
as like?
really great point. I think that's a really great point that you make, right? Because even though I'm saying, oh, Cialis is safe for a lot of people,
Yeah.
a lot of people will have a mistrust of medications, or just may say, look, I'm going to stay off medications. A lot of guys want to know, what can I do for myself at home that's non-pharmacologic? And that's where vacuum pump and Restorix can be incredibly helpful.
what might you recommend just as like I guess a regimen for them, with these things, if you were going to say, optimal, like, is it, vacuum pump once a day, or, or like, yeah, what would you tell someone in your office?
Yeah. If we say use it every day and we don't give people recommendations, they're not going to know where to start. So they're just not going to
Okay.
start, right? Or they might do it too much and cause some issues. I say a vacuum pump, the goal is 10 minutes a day. With the Restorix device, what we know from the trials is that people noted benefit when they used it 30 minutes twice a day. But do you need to do it 30 minutes twice a day to notice benefit? You do not. Even some guys who used it as little as 15 minutes a day notice benefit.
Okay.
So
Great.
something can be better than nothing. And it's just figuring out what works for that person's schedule and day to day.
Okay. Amy, I have more questions for you, but I want to be mindful because you probably have appointments. Are you able to go any longer, or do you have to wrap? Do you have a hard stop in 3 minutes?
No, I can go longer. I just have to grab my phone charger. That's why I was kind of walking around. So just bear
Okay.
with me for 1 second so I can go in
Yeah.
my room and grab my charger.
Sure. 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 Um, I'll give you a heads up, while you're finding your phone charger, of what I wanted to ask you about. And it's more about the culture, I think, in your discipline, in urology. Do you think this is something that's gaining traction amongst the more mainstream urologists? Something that might one day find its way into urology residency programs? Where do you think the field is at in regards to recognizing this stuff?
And that's one of the reasons why I can say I'm optimistic because we're talking about it now. At least within like our Sexual Medicine Society of North America, SMSNA, which is a really wonderful organization, we're talking about it. In fact, in the last few meetings, society meetings that I've been to, we've had sessions on PSSD. And the people presenting are the smartest, most talented people in our entire group. I know we're going to figure it out. I think it's going to take us some time, but we're talking about it. And people are doing research on it. And I think where the magic is going to happen is the reality is the group or the people that figure this out, it's not going to be a psychiatrist. It's not going to be a urologist. It's going to be a group of multi-specialty people in every single discipline who figures this out because we need the biochemist, right? We need the hormone specialist. We need the urologist. We need the psychiatrist and the psychologist. Like we need every single discipline involved because it really does impact so many organs in the body. It's not going to just be one specialty. It's the role of each of us.
Yeah. Um, that's really reassuring to hear that. And I may even ask you who those people are presenting at those conferences, so I can talk to them, and my audience can hear from these leading colleagues of yours, because I think it's very uplifting to people who have been hurt in this way, just to hear about the traction that that PSSD and the other associated syndromes are gaining. The last thing that I really wanted to talk to you about was, and you kind of alluded to this before we hit record, was some of your experiences trying to talk to psychiatrists about this and informed consent. So, without naming names or anything like that, please tell us a little bit about your experience, talking to my colleagues.
So when I was in at the academic institution, I was trying to sort of tackle or figure out this problem of PSSD from a variety of different angles, right? And so I identified like how can I help? Okay. So one was first I need to like talk to my patients and understand what they're going through. And two was I needed to figure out from a global perspective what's going on and what have people tried. Okay. And then from a third perspective, we needed to figure out we need to figure out how to treat it. But I knew that that was going to not be something that I solved by myself, right? At the very basic level, it's how do we educate people on the risks and benefits of medications? Informed consent, a sexy term, a term we say 5 million times a day, right? But the reality is, how do we actually have informed consent? I have informed consent often because I do surgery. So I have to go through a document with each patient I'm going to operate on and go through risks and benefits. But medications are very different. We don't have to get our patients to sign a document saying that we went through the risks and benefits, even though it's assumed that we've, gone through it with our patients. So, when I think about informed consent, um, with any medication, we need to do it. Okay. And I think one of the challenges when it comes to the mental health medications is I think a lot of people will ask, but what if this person really needs to be on this medication? And then what if I bring up the potential for PSSD or sexual side effects? And what if they say no? What if they don't want to be on this medication when they really need to be on it? Well, it's still our job to tell them. So let me tell you how I would have this conversation with a patient. And it really takes all of 30 seconds, I believe, to have a truly informed consent discussion. Before I go into that real quick, what we learned from this global survey study was that the minority of patients, it was about 12%, said they were ever told about the risk of their mental health medications related to sexual health. 12% of people. So many people are so upset with this condition because they say, I wish someone had told me. How come no one brought up these risks? I wasn't that depressed. I wasn't that anxious. And if I knew that this was a possibility, I would have said, what other options do you have? So I had a gentleman come to see me who he was in his 40s. And, if these guys come to see me in my clinic, they're oftentimes already coming in with sexual dysfunction. So I know it's important and I know it's already a concern. So I don't want to put them on medications that could worsen that. And he said, he was already making progress with our treatment protocol. And he said, I've been a little bit anxious and I spoke to my primary care provider about potentially starting this medication for anxiety. Dr. Perlman, I was just curious, what are your thoughts about it? And I said that medications like that can be very helpful to treat conditions like anxiety. But in some subset of individuals, and we don't know how to predict in whom this is going to happen, some people will experience side effects like cognitive dysfunction, including brain fog, decreased libido, erectile dysfunction, changes in sensation to the genitals, and sometimes, GI issues and other things. And in some people, even after stopping the medication, those side effects can persist. And we currently don't have any great treatment options for it. So I just want to make sure that if you're going to take a medication like that, that you just understand that in some people, and again, we don't know how to predict, that can happen. And then, you
Amy,
know what that person said? Thank you for telling me. I don't need it.
yeah, I was going to say that is the right way to give informed consent about these medications, and I just loved hearing it. And here's my belief: if people actually were telling people that about antidepressants, you'd have only 5% of the people would say I want it, compared to what is happening now. Because I mean, that is just, I mean, it's horrific, and it's not something we can estimate the incidence because it's all post marketing, reports and such. But I I love that. So
Well, the thing is, people don't
yeah,
care. No
yeah,
one has said to me, well, why can't you predict it? Or what percentage of patients have it? They're just glad that they understand that that's a risk. And then they can figure out for themselves whether or not they're willing to take it. But that's not my choice. I can't
yeah.
make that
That's their
decision for
choice.
them.
Yeah,
Yeah.
yeah. Well, I I want to thank you for letting me talk to you. I think you've got invaluable insights that are really, really important, and I know you are slightly active on YouTube as well. So I'm going to encourage my audience and people with PSSD to go over there and visit you, and learn from your insights because you've certainly got a lot of really good ones. So, was there anything else that you wanted to mention or you wanted to get across before we wrap?
The main point is that, I think that these concerns are way more common than we even realize. Um, but we have a lot of tools in our toolbox. And even though there's not one single treatment that's going to help, it might take 10 different ones to get someone a little bit better. But let's try those 10 different ones.
Well, thank you so much. Please keep in touch. Okay.